Hello, everyone. Can you hear me? Good morning. So my name is Jerry Kabado, and I will be the moderator for this session. Now, as we get started, I want us to consider what COVID-19 has done. COVID-19 has revealed and continues to cement the long-standing gender-based health inequities that we have. And more so when you consider women through their intersectional identities, be it women of color, immigrant, migrant women, lesbian, bisexual, transgender women, low-income women, and women who are differently abled. Now, the other thing that COVID-19 has done is provide us with the space and the opportunity to center women's voices. And more so in venues such as this, in a space such as this, where we can gather to examine, reimagine the institutions that impact women's health. And when we're truly fed up, to dismantle and rebuild institutions that continue to be injurious to women's health. And so this is what this first panel invites us to consider: how women's physical and mental well-being can be at the core, at the very center of discussions about healthcare going forward. And now to help us navigate these current realities, we have three panelists who comfortably straddle the policy, research, and policy practice arenas. Help me in welcoming Shannon Ginther, JD. Shannon is an attorney and healthcare executive who is passionate about connecting individuals, families, and communities. She does this with a focus on improving lives. Her expertise in strategy, defining, and creating value in healthcare has been the central focus of her career. Shannon currently serves as Senior Director of Community Health Partnerships for Ohio Health, which is a regional health system in Ohio that serves 46 of the 88 Ohio counties. With the support of Columbus Mayor Andrew Ginther's administration, Shannon recently launched and now chairs the Columbus Women's Commission, working to improve the economic security of women in Columbus. Welcome, Shannon. Next, we have Dr. Taslim Padamseh, an assistant professor and PhD program director in the OSU College of Public Health Division of Health Services Management and Policy. And she's also a faculty affiliate at the OSU James Comprehensive Cancer Center. Dr. Padamseh conducts research at the intersections of social inequality, healthcare systems, and public policies. Her major research areas include HIV and AIDS policy, reducing unsafe opioid prescribing, and breast cancer prevention among diverse high-risk women. Most recently, she contributed to the state's COVID-19 response for vulnerable populations and has recently published Ohio's COVID-19 Population Needs Assessment with her co-author, Dr. Juliana Nemeth. Welcome, Taslim. Karen Patricia Williams. As the director of the Martha S. Pitzer Center for Women, Children, and Youth, Dr. Williams leads 27 research and clinical faculty in the College of Nursing. Her scholarship is in cancer prevention control and cardiovascular disease prevention with African American women and other medically underserved women. Currently, she is leading faculty in nursing, medicine, and public health to understand resilience, allostatic load, and cardiovascular disease in African American women. Welcome, Karen Patricia. Now, before we get started, I want to remind you to put some of your questions in the Q&A box, and I will try to weave them in during our discussion today. So, Shannon Ginther, I will shoot the first question to you. And it is this: when we think about COVID-19, what is the data telling us? What has the COVID-19 crisis revealed about the inequities that women face in our healthcare system?
Sure. So first of all, thanks so much for having me today. Just a little personal point of privilege. The Women's Place was actually very important in my own professional development. I worked at Ohio State back in 2011 through 2015 and really helped me with leadership development. So thank you for that. in terms of COVID and its impact, what we've seen, unfortunately, is deepening of impact on women. And by that, I mean, broadly, from a health perspective, we see women exiting the workforce to help with childcare. And here in Central Ohio, for example, our largest school district, Columbus City Schools, still has not returned to in-person learning. And the impact on that is largely falling on women. And knowing our data in Central Ohio is that a disproportionately large number of our households are led by single women. It is disproportionately impacting women. In addition, from a more straightforward healthcare lens, a health and healthcare lens, we know that women are disproportionately on the front lines, meaning they are more likely to be in those job occupations that are higher risk, such as nurses, teachers, in the hospitality and food service industries, which, as you can imagine, are those that are most likely to be exposed to COVID. And then in terms of the impact of that, we're also seeing a large number of women delaying necessary care because they've either lost a job or because of the fear of seeking services. And those are very important services like access to contraception and access to women's healthcare services from a preventative nature. So we're really kind of seeing this, at the high level of impact on health and well-being, and then obviously from an exposure and then a personal health perspective.
Dr. Padamsee, would you like to jump in and tell us some of the findings, some of the data that came out of the needs assessment that you just completed?
Yeah, thank you, and I want to echo the thank you to you, Jerry, and to the Women's Place for hosting this really important conversation. So the study that we just published, and by published I mean publicly released, so it's available online for anybody to access freely. It has to do with the barriers that Ohio populations face, particularly our most vulnerable populations in Ohio. The barriers that people face in using COVID protective strategies in their own lives. So we know that the CDC has said there are a variety of things that we can do to protect ourselves against COVID-19. And we've had a lot of dissemination of information about what those things are. So for instance, social distancing, washing your hands, wearing a mask, but that some groups of people have more difficulty accessing those types of protections than others. And so to build on what Shannon Ginther said about women being disproportionately in frontline service industries and essential work positions and caregiving roles that expose them more routinely to the potential for COVID-19 transmission. We also face a situation in which women in many of these environments may be less likely to be able to use the protections that are there in the context of those exposures. So for instance, essential work as a caregiver or in a retail industry makes it very difficult to socially distance. It also makes it difficult to wash your hands as often as we're trying to tell people to do, or to keep surfaces clean. And especially, say, if you're a live-in caregiver, say with somebody, then keeping surfaces clean between that navigate between family members or non-family members in those environments is much more difficult than, say, if you are in a workplace where you control how much you're there, how much you're not there, which rooms you're in, and so on. So it's a question of increased exposures for certain groups of people, and also a question of decreased access to the protections that we have around those exposures. And overall, that increases the chances that certain groups of people are going to be exposed, are going to contract COVID. And because of a variety of underlying conditions and social conditions, more likely to see negative effects once they do contract COVID. So I think we're talking about systematic inequality across a whole bunch of different layers of what it means to deal with this pandemic. And the systematic disadvantages that some women are experiencing really have to do with those intersectional identities and with our highly disproportionate reliance on women in low-paid service industries and caregiving roles across the board. And I think that we are looking at long-term impacts, not just from COVID, but economically and socially. I think I'm concerned about, but I have a feeling we'll probably get to that later.
Dr. Williams, what are you seeing from the Center for Women, Children, and Youth?
Well, I think that we see our own faculty who are feeling, even though we have a lot of resources, they are still feeling stressed in a very different way. I think that we are, that what this has done is caused us to go inward and look at ourselves and then kind of understand what's going on, because when we're looking at the COVID, it's the intersection of race as well. So we know that that racism is not new. And so we have tried to understand the intersection of race and COVID a little bit better, doing a self-study. We did that this summer so that we can understand what's going on and how we fit into the larger picture. Are we part of the problem? Are we part of the solution as to how we interface? And when we see, as it relates to health disparities and health inequities, it's African-American women, it's Latinas, it's Asians who are marginalized. And so what COVID has done is it's kind of pulled the curtain back, if you will, to show all the sins. You know, we knew that they were there, those of us that are in this space, but it's kind of revealed it to others as well.
Thank you. So I think what I hear the panel saying, this being the question that launches us to the rest of this discussion, when I hear words like systemic, the social, the economic, this tells me that we at the very least have to use a social determinants of health lens to begin to understand some of what women are facing in the healthcare system, because we know that women's health is predicated on access, and in the case of Sub-Saharan Africa, access and control of their social, their economic, their political, and their physical spaces that they inhabit. Now, I'm going to go ahead and pivot a little bit and direct this question to Dr. Padamsee, and then after which the rest of the panel can kind of round robin around her. Now, Dr. Padamsee, I know that we are in the very early stages of this pandemic. We are just barely 10 months in. And I want to hearken to work that you have done where you have used a historical lens to trace a discourse and to trace the policy response of yet another health crisis, the HIV and AIDS pandemic. And I believe your work goes all the way back to the very early 1980s when we began to have a discussion about HIV and AIDS. Now, drawing lessons learned from your work, both in our local response and the international HIV and AIDS response, what can we learn from COVID-19 now, at this point, that can help us build better and stronger health systems for women?
Yeah, that's a great question. And I think as a comparative historical sociologist, I think it's always beneficial for us to look and see what can we learn from other places, other times that we can apply to what we're dealing with now. And also what we need to build for the future, because we need to, right now we need to be dealing with COVID impacts, with disparate impacts on certain groups of people, and also on the foundations of health that would eventually build the potential for health equity, which we don't have at the moment. We haven't had a health equity in this country, or in most places for up until now. And so whenever you have a system that has existing flaws, those things will always become exacerbated in a crisis, right? So, or I think this sort of alludes to what you said earlier, Jenny, about getting truly fed up, that, it's these moments that sort of help us understand the cost of the inequalities that we've been living with in society up till now. So to directly address your question about the HIV and AIDS history, I think one really important lesson that comes to mind is the idea about how we think about who is affected by a health crisis, and the impact of those discourses about who on how we're going to cope with that health crisis on a national level, on a local level, on a state level, and on our resource allocation. So when a crisis, in general, the theme is that when a crisis impacts everyone, or when we perceive it to impact everyone, which I call sort of the universalization of risk, we get a very different response than when it's perceived to impact only a specific group of people, particularly if those people are already socially marginalized, as Karen Patricia Williams was talking about. So in the history of HIV and AIDS policy in the US, for instance, American political leaders were very much not motivated to address HIV and AIDS in the first decade of the epidemic. It was because it was mostly affecting men who have sex with men and people of color. It was not considered a mainstream issue, despite the many very cogent arguments being articulated for why it really needed to be addressed at the national level. And this went on and on for an entire decade. And what turned the tide and finally brought national political attention and substantial resources in 1990 was the construction of a new narrative that anyone could get HIV and AIDS. And that transition was a result of multiple different things that happened. But it was that universalizing that guaranteed resources. So there is that upside to universalizing, right? When we understand that everyone is affected by something, we are more likely to get attention and resources. On the flip side, everyone isn't equally affected, right? Everyone is not equally affected by COVID-19. Everyone was not equally affected by HIV and AIDS, or isn't today. And so when we talk about those universalizing impulses, we also obscure the truth that some groups of people are really disproportionately impacted, and that really the socially responsible, ethical, and equitable approach is not to treat everybody equally, but to address our resources and attention to the people who are the most impacted the most, to differentiate our response so that people who have a different set of challenges, say because they're functioning as caregivers or essential workers, are getting a different kind of intervention that's appropriate for them, even if it requires more resources. So I think that tension between the specificity and the universality is a really critical lesson from past epidemics, and something we really need to pay attention to as we continue to forge our COVID response.
I want to invite the other two panelists. Now, just thinking about the very same questions, what we have learned in these short 10 months, what can we take from these lessons, or what we should have learned from these 10-month period? What can we take away that could inform care currently during this pandemic and women's care going forward, even after the pandemic, after we have a good grasp of what's going on?
I can start. So I think from a less kind of maybe a little bit less of an academic lens, I think the data really tell us a couple of things. One is that vaccine trials, this is sometimes a little understood fact, vaccine trials are actually only tried oftentimes on white men. And none of the COVID vaccines that are in stage 3 trials, which is the trial closest to getting them out into the general public, none of them have been tried on pregnant women or children under the age of 12. And so what that tells you, pregnant women, I think we know why, right? We wouldn't want to risk any harm to an unborn fetus. But for children, it's it becomes a challenge then around childcare, right? So the lesson I would say that we have yet to learn is the impact of having high quality childcare available to women. And if that is not available, and their children cannot be in school, that absolutely takes them out of the workforce. And in some ways, I would suggest drives challenges with mental and emotional health, right? In terms of their kind of contribution to their family and to society, et cetera, et cetera. And it's this impossible choice, right? Between being a contribution to society and providing for the beings that they are responsible for, and in many cases have actually physically put on this earth. And so I think that's an area where we can really learn and build policies moving forward around safe, affordable, accessible childcare, and also around vaccine trials and exactly who is involved in the trials to make sure that we get results that are not just results for white people and white men, because that's going to be key moving forward out of the pandemic.
Thank you. And I'd like to just build on what Ms. Ginther said in that as it relates to clinical trials. It's been said years ago that when America gets a cold, when America sneezes, African Americans get pneumonia. And so as it relates to the issues of what we can learn is that we know that we have always been mistrustful of the healthcare system. And so while people would like to take it back to the US public health study that was done at Tuskegee, but it goes back further than that. And then it comes forward to yesterday. How was I treated when I went into the doctor's office, when somebody met me? Was I disrespected? So we as African Americans may have a mistrust of the system and are reluctant to get into clinical trials. COVID has shown now that we aren't the only ones now, that everybody's thinking, oh my gosh, who do we trust? Who do we trust with information? So we see the medical mistrust that African Americans have had now coming out as it relates to others. So I think that we'll have to develop messages from trusted people, from people that others can feel confident in, giving us information as to whether we get into, whether we take the vaccine or not. The other is that I think that what we can see from the COVID-19 is the resilience that's there. And so sometimes we look at the glass as half empty, we don't have. But what we do see is that we see the resilience. We see women with the mask on, and they have their little kids and the little children. When you go to the grocery store, it's just something to see. But you see the forging ahead, you see the determination, and we see that as we see the long lines to get out to vote. And it takes us back to when South Africa had their first election, and you saw the long lines of people determined to vote. So at first, it was that people were concerned, and rightly so, the distancing and should I stay in line, should I go to vote in person, or should I go to, vote by mail? But you see that determination. So I think that one of the things that COVID has done is the strength. We're able to see the strength and the resilience of African American women as well as other women. And I agree with with daycare. I think that we do need, as we think about the impact that this has on the families, I think that we need vouchers for daycare. I think that we need some policies as it relates to rent, housing. We know that that a lot of times African American women, and they don't get the credit that they deserve about having others in their families with them. So we are in crowded spaces a lot of times, and for a lot of different reasons. And right now, some people feel that they need to have their family around them for support with the pandemic. But I think that we need some policies around just some basic things, just as it relates to child care vouchers, to rent vouchers, and even food supplements that, you know, we can put it on the card. We don't have to necessarily go out and go to the shelter and beg for, you know, we have to think how we allow people to maintain their dignity while we are in this situation.
I'm actually going to keep it right here at this question and take a question that has just come in through the Q&A, which I think aligns really well with what we're talking about. Shaniko is asking, with a history of mistrust of the healthcare system in mind, how do we create equitable messages for individuals of color who do not have the English competency, who are not native English speakers, or who may be undocumented immigrants? How do we create support for those who are suffering in silence?
I think that that's a really good question. And what we need, one of the things that we do know that works is community health workers. And community health workers are usually women, and they come from the community that we want to reach. So when we think about first generation immigrants or refugees, and some who have assimilated a little into the US, then maybe we can train them to be community health workers. And they can serve, because community health workers serve as a liaison between the community and the healthcare system. So people have, the work that I've done shows that, and not just me, but others who are in the space working with community health workers, show that they are a trusted individual. So when we train them and get the messages to them, then in fact they know how to communicate with their culture, with the people in their sphere, if you will, in their culture, in their racial and ethnic groups. They know the nuances that we don't know, and they're able to communicate in a different way. So I think that we could start by having community health workers, whether they're formal or whether it's an informal setting. And this is for when we think about marginalized women or women coming from other countries that may be limited resources, this is the way that people learn. Each one teach one. So this is not an unfamiliar model. And I think that it would, and they'll find it very comforting as well.
I like to second the emphasis on community health workers and all of the ways that they can work with and through and in their own communities to have a big impact. And I think that one of the best things that we can do in terms of thinking about local or state or national response to COVID is to, and the kinds of challenges that the questioner was asking about, is to figure out how do we invest in community health workers, and whether they're formal or informal, figure out how to make that a possibility, link them to resources in their own communities and also to resources that they need in order to do that work. So those people are motivated and prepared to educate their own communities. Let's make sure they have the resources they need when they have a question in order to help somebody that they're trying to help. Let's make sure that they have, for instance, translated educational materials. When somebody asks a question in a community that they're working in a language we knew people in that community are more comfortable in, let's make sure that they have materials that they can use that have already been translated into that language so that they have all of the possible supports to maximize that potential of all those connections and informal knowledge that Karen Patricia Williams was talking about, to make them as maximally useful as possible. I think there's also two other pieces that sort of build on or are around that. One is we've been advocating for a way of thinking about how do we transform or build on existing centers of community to make them centers of COVID response. So every community, all of our immigrant communities, all of our communities of color, have centers of community, trusted churches and mosques and community centers and barbershops that are centers where people already go, they already get information, they already share information, they already trust one another. Those are our best intervention points for building in new resources, new types of information, and for building in public health infrastructure too. If what we need to do is testing or contact tracing, we better do it through those same trusted places and in ways that those trusted people trust, right? We want to build up trust in vaccines. We better make sure the people who lead those communities believe that it's worth trusting, or that our contact tracers can be trusted by those community members. So taking what already exists in communities, building up the resources, and enabling those centers of community to become centers of COVID-19 response, I think is really critical. And then the other thing is, when we think broadly, and people who work in state health or public health, certain things like creating educational materials and stuff like that, that's the low-hanging fruit, that's the easy part. Even when we think about that, we need to be thinking about what languages do people speak, and how literate are they in written language. So if we need to be producing videos or social media content instead of pamphlets, then we need to be doing that. If we need to be doing it in a language, if we need to be doing it in Somali, then we need to be doing it in Somali. Oh, and we have a lot of low literacy people in all languages, including English dominant speakers, for whom the kind of healthcare materials that we produce aren't necessarily all that accessible. So we can overcome that. There's a whole understanding of how to overcome those kind of communication barriers using pictures, storytelling, and other mechanisms that would allow us to communicate better with a broader range of people, regardless of literacy or language.
I would just add on to that a couple of other resources that I think are in this kind of hub and spoke model we're talking about. One is public health, the public health department specifically, and this is the mission of public health departments, right? Is to reach and serve those who are underserved, marginalized, may not speak English as their first language. So I think that's a key component. So it's really about the community health workers, and yes, the community focused resources, depending on the community we're trying to reach. But then it's also partnering with public health, and then with, our different resources here in our communities that help folks who are relocating. So folks who are either immigrating or have, immigrated to another city and maybe relocating to Columbus for whatever reason, places like Jewish Family Services and others. We do a lot of work at Ohio Health. We do a lot of work with Jewish Family Services because they, while they help with relocating Jews, obviously, they also help with relocating folks from many, many other countries. And so how do we partner with them to reach those communities and provide resources to the communities in ways that those communities are used to and are trusting of kind of investing those resources. So that's kind of the other key piece. I think it's the on-the-ground support of community health workers that we've talked about, but also this web of support services, making sure that we're connecting all of those pieces to help people feel comfortable that the healthcare they're getting or the request to get vaccinated, or that's something that they can trust.
I think I always get very excited whenever people start talking about collaborations, when you're collaborating with people on the ground as community health workers, collaborating with our small ethnic-based community organizations, that I think they're really nimble. These people are really nimble. I know, for example, it's only been, 9 months of COVID-19, and the Bhutanese Nepali community has organized a statewide sort of model or intervention where they're providing care and providing information around COVID-19. So our community-based ethnic organizations are especially nimble, and I think we would serve ourselves well if some of our bigger human service organizations were actually partnering with these smaller community ethnic-based organizations. I also really like the fact that we talked about language isolation. That's a real thing, providing information or messaging in a way that is accessible to as many people as possible in the state of Ohio. Now, I want us to try to think beyond COVID-19, if that is even possible in this day and age. And Dr. Williams, I am going to start with you on this one. Now, what are some of the major health issues that are facing women that maybe aren't receiving adequate attention? And the second part to that question, is, are there any communities or groups or subpopulations of women who are especially invisible in the healthcare system?
Well, that's pretty large, but I think that so one of the things we know that it's October, and everyone knows that it's breast cancer month, right? So we see all the pink ribbons we're wearing, and and that is extremely important because that's the first cancer that women get and that we know about, that we think about, that triggers in our mind a lot of times. But one of the things that I think that we don't consider is cardiovascular disease. And cardiovascular disease most recently, and this is the #1 killer of women and men, period, in the US. So, but, we think of it as, it has been traditionally a disease of aging. So it's not on our radar. However, what we do see is that African-American women and Latinas are presenting in their 20s as far as how they look. The CDC tells us how they're looking like older white women. And so they're at higher risk for cardiovascular disease. And I think that we don't realize that. And if we put one of the things that we also, we have a paper that's getting ready to come out that shows that even when we have breast cancer and gynecological cancers, that they are triggers and risks for cardiovascular disease. So we don't even know that, we're just thinking one disease. And I think that we have to just stop thinking just one disease, one off, but we have to look at the total person. We have to look at the mental health. We have to look at where is she living? Where's her environment? Where did she come from? Where was she raised? Because we might be living in New Albany right now, right? But if we were raised on the other side of the tracks by the some kind of plant, if you will, some kind of manufacturing plant, then that has implications as far as our health. And so sometimes we don't consider that. But I think that we need to not look at women fragmentedly, just not fragment ourselves so much. I know that that's how we get money and that's how we do our work, and we're specialists as a result of that. But I think that we have to look at the total woman, the total package, because, you can't isolate her and not consider the environment, the social and the physical environment in which she lives, and its contributions to whatever the chronic illness may be. So I'll just stop there.
Thank you. Shannon, are there any other medical issues that you were seeing out in the universe that are probably still flying under the radar?
Yes, and a couple of these I think are even a little more, let me call it, Pavlov's hierarchy of needs. So one is food. 54% of people who report they don't have enough to eat are women. And oftentimes then the families that go along with these women. And of course, if you don't have food and you don't have shelter, there's no way you're going to have access to the resources and going to be even focused on the resources like, did I get a mammogram? So I think food is key, hunger. And then also violence, domestic violence specifically. This is an issue that there's much concern around this increase we've seen in domestic violence. I heard recently that Choices, which is our local domestic violence shelter, one day early on in the pandemic had its highest number of calls ever. So we need to think about that. And while you asked specifically beyond COVID's going to have a long tail, especially for folks who are low income and, the low wage jobs, because those are going to be the last jobs to come back which means the most stress in those households, driving more domestic violence. So that's definitely an area of concern as well. And then I think the final thing I would highlight, and I actually want to read the statistic around reproductive health. 1/3 of US women reported delays or cancellations in sexual or reproductive health care, with a higher proportion of reports from Black, Latinx, LGBTQIA, and other low-income women. Women in these groups also report more concern about their ability to access sexual and reproductive health care services, particularly contraception. I touched on this before, but if you don't have access to what you need so that you can make choices around pregnancy and reproduction, that again has a long tail in terms of concerns about women and their ability to make choices around when and how they start family.
I think we're going to stay at this point of talking about access, agency, and control for another minute. And I'll take another question from the audience, and I'll read it out to you, and anyone can pick it up. In August and September, 865,000 women dropped out of the labor force. This is compared to only 216,000 men. What needs to be done through the healthcare, public health, and policy to address this enormous disparity and adding to women's poverty and discrimination?
I think we probably all have thoughts on this one. This is a huge issue, so I'll just throw out a couple things. I mean, I think what Shannon said about the long tail is worth remembering here. These impacts, impacts on professional trajectories, women's careers, household economics, and gender inequality in household economics are going to be really long-standing issues, and we do need to be addressing them now. We also need to be prepared to address them later. I think, which is, right, the definition of a long-tailed issue. I think with respect to now, I think that workplaces need to be thinking as broadly as possible about what does it mean to accommodate the kind of strains that we are seeing and the ways that the underlying inequalities that pre-exist COVID, sorry, we did end up back at COVID, the underlying inequalities, what does it mean to understand how those underlying inequalities are causing these effects? So we know why many more women are dropping out of the workforce. It's the same reason why in my own field of academia, overall, like, publications and grant applications are stable or up across fields, except those that are coming from women, which are mostly down, and by a significant percentage. That is, again, going to have a long tail, even for women who are in a job that is professional, that is allowing them to keep their job despite additional strains from home. But it's not the same, right, as having the same capacity to work at your job that you were before in terms of your economic longevity or your ability to advance in your career. So we need for professions and workplaces to be thinking about, how do we deal with that now? How do we deal with the fact that women are producing differently and are contributing differently in their workplaces and professions right now, and that is not a product of choice or whatever. That is a product of the structural conditions that underlie the crisis in which we are living. And how do we adapt things like promotion, hiring to bring people back in, to bring women back into the workforce, in order to deal with that long tail that's going to come later as a result of all of the things that women didn't do in their careers now, because they were trying to just survive in the midst of all these extra strains, and also when they had to leave, not necessarily by choice, the labor market, and then need to come back.
Okay. Does anyone else want to piggyback? We just have 3 minutes left in this session.
I would just say that, and I agree with what's been said. I think that we need to think about undergirding our education system, because we need training, and we need different types of training. We're going to need retooling. What COVID has shown is technology, and who has access to technology. who knows how to use technology. And we need to, and beyond our cell phones, if you will, or beyond the Facebook. So I think that we're going to have to look at retooling. Women are going to have to retool themselves so that once we move forward, that we are competitive. So that will mean things at the high school level. It will mean different types of training at the community college. But I think that we're going to have to look at how do we retool? How do we, because it's going to be a different world. And some of the jobs that we used to have before, they're not going to be available. You know, for instance, it'd be interesting to see how commercial property or commercial real estate, when people can work from home now. So what does that mean to our buildings, whether here in Columbus or otherwise? But I think that we're going to have to look at understanding it and put money into infrastructure as it relates to education.
So I would just add, and I know we just have a little bit of time, but I'm struck by the fact that it feels like this panel is kind of a lot of bad news. And I do think that while we know that COVID looks very different from the 2008 recession in terms of its disproportionate impact on women leaving the workforce, there are things that are happening in Central Ohio and across the country, companies that are very interested in doing the right thing, laser focused on how they can retain women and people of color in the workforce, promoting, training, accommodating, that I think was brought up before. The Columbus Women's Commission is actually convening a group of about 270 companies here in Central Ohio who signed on to the Pay Equity Pledge. And now what we're focused on for this next year is how to retain women in the workforce. And we've had some difficult conversations, I would say, about challenging leadership at some of our major companies to update outdated thinking around productivity at home, around how and when people get their jobs done, and whether or not it really takes 8:30 to 5. So there are positive things happening, albeit, you know, there is still going to be a long tail. I'm not suggesting that this work is going to change all of that, but know that there are companies out there that are doing absolutely the right thing and asking the right questions and challenging their thinking to the very highest levels of their leadership.
Thank you. Now, in the last minute, we have just 1 minute, and I'm going to pose a challenge to our panel. I just want you to use 1 or 2 words. Thinking about the work that you do, just in 1 or 2 words. What is that one gettable win? That one thing, if we achieved in women's health in our lifetime, you could sit back and say, we did good. So I'll start us off. For me, it is the total eradication of all forms of female circumcision all over the world. That would be my one gettable win.
Mine's childcare.
Mine is health equity.
Tasneem?
Those are all great. I think it is the ability of women to implement the choices that they make for themselves.
So thank you very much. And I see a few people in the chat are actually putting in their gettable wins for our lifetime. I really want to thank you all. Thank you for a very engaging conversation. And I invite the audience to thank Shannon Ginther, Tasneem, and Karen Patricia